All right, so welcome everyone to this part two Talks on Tuesday on postpartum, recognizing and supporting the impact on the parent-child relationship. If you guys have not seen part one, I'm going to go ahead and post that into the chat for you. All of our Talks on Tuesday webinars are archived already, and so you can always get access to any of those and take the survey and receive a professional development certificate for that training. But my name is Lisa Terry. I'm an early intervention professional development consultant with VCU's Partnership for People with Disabilities. I also have Corey Hill and Dana Childress from our team, also providing some backup support behind the scenes. I am going to go ahead and get us started because we have a lot to do today, and Telisha is going to share some great information with us. So I'm going to go ahead and pass it over to Telisha, who a lot of you may already know from the Part C state office, but we're just so excited that Telisha is really sharing her expertise in postpartum and supporting those parents. So go ahead to you, Telisha.
Thank you so much, Lisa. Hello, everyone, and welcome to part two of the Talks on Tuesday series, Postpartum, Recognizing and Supporting the Impact on the Parent-Child Relationship. As Lisa stated, my name is Telisha Woodfin. I am a monitoring consultant for the Richmond and Tidewater regions with the State Part C office. And additionally, I'm the founder and lead postpartum doula at Live Love, the postpartum family support agency. Today, we're going to take the objectives from part one for those of you who participated in that, and we're going to apply them to a few special populations. So our specific objectives today, again, are to review the definition of postpartum and how it applies to early intervention, to explore the needs of special population families postpartum, discuss the role of an early interventionist, and again, to provide strategies that support the parent-child relationship. And so for those who were with us the first time, you know that we took these objectives. We were learning the definition of postpartum at that time. But this time, we're going to take those same objectives and we're going to apply them to special populations. In early intervention, we deliver family-centered services that are supported by coaching as a means of interacting with families. It is important that we remember that the infants and toddlers we serve come in a package that we call families. So those of you who were with us last time, you know that we talked a little bit more about that. Families can be diverse in nature, and so can pregnancy. Pregnancy and birth are commonly assigned to women. However, many people who do not identify as a woman are capable of getting pregnant and giving birth, and they do. Like women, they too require prenatal, perinatal, and postnatal care. So throughout today's presentation, you will hear me use the term birthing individual rather than mother to be inclusive of all individuals that give birth. So let's review the definition of postpartum. Postpartum is the period of time after childbirth. All birthing individuals experience postpartum. During the postpartum period, a birthing individual is adapting to multiple physical, emotional, and lifestyle changes. And we're talking about physical recovery, adjusting to changing hormones. They're learning to feed and care for a newborn that is also adapting to life outside of the womb. And we're not just talking about individuals or birthing individuals who are giving birth for the first time. We're talking about with each individual pregnancy. The physical recovery can be different. The adjustment to hormones can be different. How we feed and care for our newborn with each pregnancy can be very different. Early intervention naturally intertwines with postpartum because we are oftentimes providing supports and services to families during the postpartum period. Through the use of natural learning environment practices and coaching practices, we support parents to support their children. A birthing individual or a caregiver's ability to support and care for their little one is very much dependent on their ability to receive support and care themselves. So in part one, participants filled the empty box on the screen with abilities that might help us as we support families during the postpartum period. Some of those abilities were patience, active listening, empathy, compassion, self-awareness, and listening and giving space. As we talk about a few special populations today, I'd like you to consider how these abilities might show up in our work with those families. Now, before we proceed, and I know that there are folks that are still joining us, but I want to acknowledge that the information that we're going to discuss today may be triggering for some. And I want to encourage everyone to give yourself the same compassion and attention that you give families. Stay attuned to your body and your needs and excuse yourself if you need to. That's really important. So take care of yourself during this time. In early intervention, we are not strangers to infants exposed to substances. But today, I'd like to focus on the birthing individual's substance use. The quote above is from Brene Brown's book, Dare to Lead. And I'm going to take this opportunity to put in a plug for Dana and I. We're going to be co-facilitating a leadership book study on this book that's on the screen later this year. I believe the actual time is going to be in December. You guys, if you're interested, please keep a lookout for an email announcement that should be coming out in the next month or so. And this again is a leadership book study, and it's going to be for system managers, leaders, supervisors in early intervention. But the quote above, it reads, leaders must either invest a reasonable amount of time attending to fears and feelings, or squander an unreasonable amount of time trying to manage ineffective and unproductive behavior. You might be asking yourself, how is that relevant to today's discussion? Well, this next exercise that we're going to do is going to require you to practice professional vulnerability. And we touched on that briefly at the end of our last session. Brene describes vulnerability as uncertainty, risk, and emotional exposure. I believe that professional vulnerability is about acknowledging our own actions, thoughts, ideas, no matter how imperfect or flawed they are. Then reflect on those actions, thoughts, and ideas, and evolve from there. This process is necessary for us to change the narrative for the EI families in our community. So over the next minute, I'm going to share a series of photos. In chat, I'd like you to share your gut reaction when you see the photos. I don't want you to overthink it. I just want you to put in chat your gut reaction, and they can be thoughts or feelings that come to mind when you see these photos. Here we go. I'm seeing dangerous. Let's talk sad, scary. Oh no, don't, thoughtless. Keep going. Babies will have to live with the choices mom makes. Ask for help. How can I best support? No. Oh no. Oh, don't. Irresponsible. Oh dear. Need some education. Whoa. Please don't. Unaware. Worry. Stress. Addiction. Dangerous. I wish you wouldn't. Unhealthy. Yikes. Thank you guys for doing that. Our gut reaction or our initial thoughts about the images represent our perceptions of people with substance use disorders. And these perceptions are often called unconscious or implicit bias and can impact the work that we do with birthing individuals dealing with substance use. It is important for us to first acknowledge how we think about the issues that our families are faced with before attempting to provide support to them. So we've actually just taken the first step today. And I realized that, you know, there's so much judgment that can come sometimes from even us with each other as professionals about those thoughts, but it's really important for us to be honest about our thoughts and feelings regarding different issues because of what I just stated. It's important that we face those things before we attempt to provide that support to our families. How do we change our implicit bias about substance use? And while I am specifically going to talk about substance use, know that any implicit unconscious bias that you have, these strategies can be used to change any of those. And so first we acknowledge our thoughts and our feelings about the substance use or whatever the issue might be, which is what we just did. We gain an accurate and science-based understanding of substance use disorders as a medical condition and not something that an individual is intentionally doing to harm themselves or others. We change our language to reduce potential for stigma and negative bias, removing language that negates or equates people with their condition. For example, a baby with neonatal alcohol syndrome or a baby with ENAS, or a birthing individual with a substance use disorder versus an NES baby or an alcoholic. That's one of the ways that we can begin to change our language. And remembering that we serve from a place of support and not from one of judgment. We want to ensure that our perceptions, judgments don't contribute to the stigma surrounding substance use that prevents birthing individuals and others from getting the health care and treatment that they need. We should assess the needs of all families on an ongoing basis, and that ongoing assessment and the information gathered from it is what makes each family service plan individualized. We educate, we encourage, and support caregivers in a way that builds competency and confidence in their ability to take care of themselves and their baby. Now, while there are countless reasons that individuals use substances, given what we've learned about the postpartum period, as well as considering some of the social, financial, emotional, and physical challenges brought on during this time, not to mention possible trauma, it is not surprising that many birthing individuals struggle with substance use. And it's probably less surprising that statistics show that there is a high correlation between postpartum depression and substance use. Now, I'm not going to get into a deep discussion about substance use, but I do want to talk for a moment about how substance use withdrawal impacts the birthing individual or the caregiver and their interactions with the infant. And I want you to think about what you see when you go into homes of birthing individuals that are going through substance withdrawal. Physically, they might be restless. They may feel depressed. They might be fatigued, nauseous, irritable, agitated. They may even experience flu-like symptoms, while also dealing with some of the physical postpartum recovery symptoms, which can include abdominal pain, constipation, hemorrhoids, episiotomy and incision care, soreness, hot flashes, cold flashes, after pains, vaginal bleeding, incontinence. The list goes on and on. In part one, participants shared that the postpartum transition can be described as tiring, exhausting, stressful, hard, emotional, lonely, and overwhelming. And I share this to give you a vivid illustration of how withdrawal can exacerbate postpartum or vice versa, and make it even more difficult to adjust to parenting a newborn and take care of themselves in the process. Not only that, but it can create challenges in the attachment process, which we talked about a little bit in part one, as it may interfere with the parent and the baby getting to know and understand each other. Consider the unique opportunity we have to advocate and support not only the child, but that the importance of the parent-child relationship and its impact on child development. It's an opportunity to change the narrative. As a follow-up activity to this presentation, I'd like you to consider having a discussion with your colleagues about how this information can inform your practice in your locality when supporting birthing individuals going through substance use withdrawal. Another special population we're going to talk about are NICU families. For parents, the experience of having an infant in the NICU is traumatic. We're going to take a look at 2 birth experiences. These are real stories. However, names and dates have been changed for confidentiality. The summaries provided are not templates and are being used solely for the purpose of today's discussion. So I want to introduce you to baby B. And handouts are available for this presentation with resources as well as with the birth stories that we're discussing. Thank you so much, Lisa, for dropping that in chat. Baby B is a 3-month-old male born July 1st, 2021 at 27 weeks gestation via vaginal delivery, weighing 2 pounds and 6 ounces. Post-delivery, baby B was breathing on his own within 24 hours. He was discharged home from the NICU on August 26, 2021. 9 days following discharge, baby B was admitted to the hospital PICU due to apnea. He was placed on a ventilator for 10 days and stayed in the hospital for 3 weeks. It was later determined that the apnea was due to viral meningitis. Baby B was referred to early intervention due to prematurity, atypical feeding, and torticollis. Additionally, he has kidney damage and is at risk for vision and hearing delays. So pretty typical, right? We get premature babies in early intervention all the time. While the story is unique, we are not unfamiliar with premature deliveries and premature babies coming into services. If you remember the last time I talked about the questions that we ask and the importance of digging deeper into the story and how that information that we gather can be particularly helpful as we support families. So I'm going to share with you the rest of baby B's story. Mrs. B shared that this is her 2nd pregnancy. She explained that this pregnancy was considered high risk due to diagnosis of incompetent cervix during her last pregnancy. She explained that when she initially went to the hospital days before baby B was born, she was told she was having Braxton Hicks. When she returned, she was sent to another hospital that could handle preterm labor at 27 weeks gestation. Ms. B explained that she began to think about her first delivery, which she described as traumatic because she felt dismissed by hospital staff when she told them she was in labor. She felt that she had to have an emergency C-section with her first son because the staff didn't listen to her. She said that she was told she would not be able to have a vaginal delivery after her first child due to her having a double cut C-section, yet she was told to push during the birth of baby B, which is why she delivered him vaginally. She shared that the delivery was very confusing and happened so fast, not to mention that after being told about all the risk involved with having a baby at 27 weeks, baby B was born inside his amniotic sac. She described the look of horror on the nurses' faces, coupled with the speed in which they whisked him away, that caused her to believe that baby B was dead. Mrs. B shared that she returned to work when baby B was 4 weeks old so that she could save some leave for when he returned home. She recounted crying to and from work, feeling resentful towards her partner, thinking that he could do more to help with the toddler. Mrs. B recalled her husband finding baby B unresponsive only days after being discharged from the NICU. She vividly described the specific instructions she had to give her husband as he appeared paralyzed from the experience while she administered CPR to baby B until the ambulance arrived. She shared that he coded 2 more times before getting to the hospital. And she later learned that the virus that caused the meningitis was the common cold. She wondered how this could have happened as they practiced extreme caution and no one in the home was sick or had been sick. Ms. B shared feelings of uncertainty, not knowing if baby B would get sick again, if he would stop breathing again, if he would develop like other children, or if he would have a normal life. Despite all of these overwhelming thoughts, she was certain of one thing. She was glad he was finally home. So I want to pause for a second, and I want you to just in chat share some of your initial thoughts just after hearing the rest of that story. Any thoughts? You want to cry for her, but a lot to wrestle with. Mom needs support, absolutely. PTSD for this family. The parent has been through some unimaginable difficulties. Mom is so overwhelmed. This is a lot and she needs help to process, absolutely. Scary for mom to almost lose her newborn. Yep. And probably happens a lot. I agree, Robin. I think this probably happens a lot. So glad mom felt comfortable telling her story. Absolutely. And it's important to remember that some parents won't, and that's okay. The importance, remember we talked about those abilities that we take in the home with us, listening and giving space. How traumatic for this family. Let her talk, listen, change the trajectory of the relationships. Absolutely. Absolutely. And just think about that we may have never known this information had we not asked the questions. And also think that I know for me, listening to the story brought about some feelings inside of me, right? And we talked about those, and we talked about the importance of not pushing past something because we are struggling with it ourselves, or it's uncomfortable to us as professionals, and truly giving space to parents to share their story and sit with that. We don't need to solve it. We don't need to always offer advice. We remember that our role is as the EI provider coming into the home, or the early intervention service coordinator. But we give the family that space to share their story so that we can support them appropriately in the IFSP. And it won't always require a service to be added or anything like that, but it gives us the information so that we can support families in the way that they need support. So I want to share with you a few things. So after listening to this story, I asked Mrs. B to share her worries, wishes, and wonders as it relates to early intervention. So pictured on the screen, I am sharing with you what those worries, wishes, and wonders were. And so based on the information that's on the screen, and I'll read a couple of those, I want us to think about some ways that we can support Miss B. So her worries, will he get sick again? And you guys feel free to start typing as I'm reading. You don't have to wait until I'm done. Will he get sick again? Will he develop like other children? Will he have a normal life? And again, in chat, you guys are noting some ways that we might support this family. Her wish, that someone would reassure her that he's going to be okay. Wish that someone would reassure her that she's going to be okay. I think that might be on there twice. Wish that she would focus more on that they would focus more on the strengths than deficits. I wonder if they really hear the emotion behind what I share from one session to the next. I wonder if they knew my story, if they'd be more compassionate. I wonder if my son is just a job to them. So a couple things. Yes, Tracy, I see. Hold space for the child and the parent. That's great. Absolutely. Listening to the story. And you're right, Joanne, we can't promise that we can be okay, but we can promise and reassure her that we will not go anywhere, and we will do the best. We would do our best to support her. We absolutely can do that. We can promise to do our best. Yep. Thank you, Michaela. Sensing the parent needed validation, reassurance, empathy. Ask mom what her prior knowledge is about development of premature babies. Support mom by sharing that all parents wonder about many of these things. Help to normalize her experience. Absolutely. And it sounds like mom might be dealing with some grief, right? But definitely all of these things, listening to the story, reassuring a worried mother, because while there is a child that is premature, there's also a mother that's concerned about her child, which I think we all, or a birthing individual that is worried about their child when we go in. And those are concerns that are across the board for all families. I think when we come into the picture, most families want their children to do well. They want them to develop appropriately. Thank you guys for doing that. So baby D, I'm going to introduce you guys to baby D. Baby D is an 18-month-old female born February 15th, 2020 at 36 weeks gestation via emergency C-section. Baby D emerged weighing 7 pounds, 11 ounces. Post-delivery, she was in the NICU for 25 days. During that time, she spent 2.5 weeks in an incubator under UV lights due to high bilirubin levels and was on a CPAP machine. Baby D was discharged on March 7th, 2020 with an apnea monitor. Baby D was referred to early intervention due to suspected delays in her motor development. And so just so you guys know, we're dealing with these scenarios in real time. So that means that baby D is getting to us at 18 months. And I just read off baby D's birth history. So let's explore a little bit, again, the rest of that story. Baby D is the youngest of 3 children. Mrs. D describes all of her pregnancies as complicated and high risk due to diagnosis of 2 autoimmune diseases and uterine atony during previous pregnancies. After baby D's delivery, Mrs. D learned that an intra-amniotic infection caused baby D's rapid heart rate, which resulted in the early delivery. Mrs. D describes the delivery as traumatic and shared that her physical recovery was painful, but faster as she was motivated by her desire to see baby D in the NICU. She recalled how helpless she felt after baby D's birth as she was being given CPR and rubbed to increase her cry. She reminisced on how she couldn't be by her side because she was being stitched up from the C-section, and she felt she couldn't be there for her husband either, to reassure him that everything would be okay. Emotionally, she shared that she grieved the loss of what she expected. She shared that she felt detached from baby D at times as physical touch was only allowed every 3 hours in the NICU and was limited to her assisting with care, such as taking temperature, changing diapers, etc., with medical supervision. She shared that she experienced moments of frustration and anger with hospital staff, resentment towards her partner, and feeling isolated. She expressed having mommy guilt with her 2 girls at home and often wondered what she could have done differently. Mrs. D explained that she waited to make a referral to early intervention because she hoped baby D would catch up, and she was afraid to invite someone new to meet her because she was protective of her and didn't want to think that she was not doing the same things as other 1-year-olds. Additionally, she was suspected to have pneumonia at birth, and she would get bronchiolitis with every cold. So she thought, why introduce her to new people? Mrs. D disclosed that this was the first time she has let anyone interact with baby D outside of those in her household, her sister, and physicians. So after listening to this story, I asked Mrs. D to elaborate on why she hesitated to refer baby D for services after being encouraged to do so on 2 separate occasions by her physician. So for those who are looking at this and they're trying to figure out how in the world did we not get this referral earlier on? So this baby D was referred at birth to early intervention. And then again, the physician recommended that a referral be made to early intervention. And mom at that time decided to go ahead on and do that. And so what you have on your screen is why she decided to wait. And what she shared was that she was worried that providers wouldn't have empathy for her story, which felt to her like a lifetime. What she needed, acknowledgement or understanding of all that they had just gone through with baby D. And again, realizing that to Mrs. D, this felt like a lifetime. So while baby D is 18 months, this still feels very real and very recent to this family. So in chat, I'd like you to share some ways that we can practice empathy with parents and acknowledge or demonstrate understanding of their journey. What are some things that you think that we can do? This makes me think about my own bias that I have sometimes when I wonder why didn't they refer sooner, but that in the grand scheme of it all, it doesn't matter. And they are here now and have their own story I don't know about. Good, good. Thank you so much for sharing that, Lisa. Listen, don't fix. Yes, meet them where they are. Ask questions sensitively and listen actively. Great. Listen, seeing a lot of listen. We're going back and we're grabbing that stuff from our box, right? Listen with curiosity. Reflect her story back to her and ask questions about how she's feeling. Validate her fears and her protective instincts. Absolutely. Validate without the but. So good. Stay attuned to mom's needs and behaviors. Yes, because if you remember, and I didn't have this as a handout this time, but we did in part 1, is that sometimes birthing individuals can't tell you what they need. They don't know. They're so overwhelmed that they don't know what they need. But for those of you guys who were with us last time, we did the Wheel of Postpartum Need, and we brought that out, right? And that's a tool for us, but also a tool that we can use with families so that they have something tangible and visible that can help to figure out what those needs are. Helping mom build supports for her needs, sometimes echoing back what was just said allows the family to know we are interested and give them more information. Absolutely, that's the definition, Mary Ellen, of active listening, doing just that. Validate Mrs. D for her advocacy for her child. Absolutely, because sometimes we're the first professionals that families are getting to where that validation for all that they've dealt with is happening, because everybody prior to this is just giving them orders. Right. And so recognizing again, and I've said this, and I know it sounds really cute and maybe cliche about we're providing services to the most sensitive and vulnerable population that we have. But that's the truth of it. And we're not just talking about the children that we're serving, but we're also talking about the families that we're serving. So remember to handle with care. To remember to handle families with care. And Lisa, what you said earlier was so key, because we do have to remove all of our judgments when we get referrals that come in, and we get so passionate about our work sometimes that we're like, why didn't this kid get into it sooner? You know, I'm guilty of it. I've seen it. I've done it with the 2.5-year-old that isn't talking. And I'm like, where has this kid been? And we don't know any of the stuff yet, right? About what has happened up until this point. And so remembering that, to just lay all of our judgments down and just provide the services and the supports that families need. Always use your wondering skills. Absolutely, absolutely. And so I have one final story. I'm looking at the clock and I'm so excited that I have so much time left, because I'm going to share a story with you guys that we're going to get a chance to process, like we did the other two as well. And so this next and last story is about a young woman named Jane. So I'm going to tell you about Jane's story. In 2014, Jane and her boyfriend at the time, now husband, were told that she would never be able to conceive. They both took it pretty hard, but remained somewhat hopeful. And in 2017, they were told again that the chances of them conceiving were very small. Despite what they were told, Jane and her husband began exploring fertility options and conceived a baby boy in 2019. He was born at 35 weeks, weighing 5 pounds and 6 ounces. Though he had a few complications with blood sugar levels and jaundice that caused them to have to return to the hospital for support, Jane made a conscious effort to be mom and not a developmental clinician, not a service coordinator. She needed to be the subjective mom, not constantly analyzing her baby. Jane did notice, however, that around 3 months that he still had a lot of preemie quirks, including being extremely stiff and twitchy, trouble latching, and he didn't cry much. She mentioned it to her pediatrician, who she felt brushed her off. Jane thought that this may have been due to her being a first-time mom, being young, or maybe it was the fact that she had 2 degrees in child development. Nevertheless, Jane refused to give up and continued to share her concerns, which now included that his head was very flat and that he wasn't rolling over at 6 months. After an evaluation by a private provider, baby S was diagnosed with moderate to severe bronchicephaly. The pediatrician still had reservations about the concerns and did not approve a helmet through insurance, but rather referred for a second opinion from a provider whose wait list was 3 months long. During this time, Jane self-referred baby S to early intervention, and he began receiving weekly physical therapy. At 10 months, baby S was atypically crawling, but still not rolling over. Around his first birthday, he was diagnosed with torticollis on both sides and a class 4 lip and tongue tie. Baby S had his midline tether released earlier this year. Jane shared that one of the most frustrating things about her experience was feeling like she needed to defend herself as the mom, constantly leading with a disclaimer that she isn't crazy or overreacting. So we have the unique honor of having Jane here with us today. And she's going to take some time, and we're going to talk a little bit about that experience that she has. And just so you guys know, her name is actually not Jane, but it's Jane in this story. And so I'm going to stop sharing. And we are going to welcome, I got to change my own view. There we go. Hey, how are you?
Hello, I'm great. So honored to be here.
Thank you so much. So this is Michaela, you guys. Thank you so much for joining us, Michaela, and for allowing me to just share your story. And this is just a summary, right? I know so much happened that was not captured in this story. But before we dive into that, I would like for you to take a moment and just share a little bit about yourself with the folks that are with us today.
Well, my name is Michaela Morgan. My role as an EI professional is I'm a developmental services provider, and I'm a service coordinator. And I'm the mom of a almost 2-year-old in November, and one on the way who we just found out is a baby girl.
Congratulations.
So we are really excited, very blessed, that we've got not only one, but 2 miracle babies.
Absolutely. And after hearing your story, we know that this is after being told that that would never happen. And so we know that it is truly a miracle. So congratulations to you.
Thank you.
So we want to talk to folks today just about, I want you to share how being an EI professional impacted you as a parent and your experience with your son.
Yeah, I've been toying with this because I feel like it's sort of cyclical. My experience as a parent shapes, how I, practice as a professional. But I think already being a professional and then becoming a parent, I already had somewhat of an understanding of what to expect from early intervention at face value. I understood the importance of collaboration and validation and empathy, but I didn't fully grasp how much that would be needed from me as a mom. And I love that we've been talking about validation so much today, because it got me thinking, like, why do we seek validation so much? What is it about being validated and feeling heard that helps us to connect? And I think what I was needing most from early intervention at the time of referral was I just needed to trust somebody other than myself, because having all your trust in yourself can be exhausting. And as a new mom, navigating, working, and wearing multiple hats, and now trying to be an advocate, I needed to just place that trust in somebody else's hands. So the way that I learned to trust was when people validated me.
That's a
heard
good
me.
point. That's a good point, because I don't know that we like, I think that sometimes we know things, right? Like we know what validation means for us, and when we receive it, we know how we feel, but really just understanding the importance of that. So thank you for breaking that out and sharing what that really meant and exploring that, right? Because I imagine at the time you probably were not thinking about that at all, but absolutely reflecting on that to be able to pull that information out of that situation. So yeah, the importance of validation.
And I think as a professional too, you kind of have to gauge, I mean, use your gift of intuition. How can I help this parent to trust me at their own pace? And like you said, give them the space and give them the grace, and the space to just share and be heard and sit in it. And like I said, validate without the but. You know, there's validation, but oftentimes we feel that we want to fill the space. I know this is hard. This is so tough. I see that you're struggling, but look what you've got. Look how great he's doing. And sometimes we don't need that part. We just need to sit. I'm here with you in this moment. This sucks. Or, you know, I'm whatever you need, I'm here, and just leave it at that. And I think in that space, the parent can really feel connected to you, which, you know, connection establishes rapport, is conducive to learning and growth and all that. But I think that's such a tactical thing that we as providers can do to help get that going and open that bridge.
Wow. And, you know, it's really about relationship is what I hear you talking about. It's about relationship. And we have the opportunity to practice, because we're talking about supporting and recognizing parent-child relationships in postpartum, right? And so we have the opportunity to model good relationship and relationship development with those parents during a time that we really want them to do the same thing with their child, right? And so we are giving them the space. So I think so that they could also give the space for their baby, right? And so it's really about relationship. And I don't know about you, but when I am establishing relationships, it's not on the timetable. Like I have to be genuine and authentic, and it takes time. And some people you naturally connect with easier than others, and some take work. You know, some take a little bit more work. And so we are really establishing relationships with our families. And that's what allows us to be able to build on some of those things that you mentioned.
Yeah. And I also think the pace at which you can develop trust is heavily dependent on what phase or level that parent is on the grief scale, what stage they're in, if they're in a stage. But my guess would be that most of us at some level as parents, especially in this program, are or have experienced some level of grief, or you know, and so I think you have to recognize that, because the first step is trust. The first step in order to get anybody to learn from you or to grow with you, collaborate with you, they have to understand and honor what you're saying, and they have to believe it, you know. Right. So being able to connect with them on a level that feels like you got their soul, you understand it, and you're taking care of it, and you're taking care of it in the most precious thing in their life right now. You've got it in good hands. Yeah.
Absolutely. Absolutely. Is there anything else you want to share with us, Michaela?
Yes, I do. One of the most important things that I learned from EI, from my lovely, wonderful provider who has since retired and is living her best life now, was that it's okay not to have an agenda. And sometimes, in fact, it's better not to have an agenda. She so got me. One of the most influential things that she said to me that just it sticks with me every day as I'm in the thick of like, okay, we're learning, what do I want to work on today? You know, how can I make this 45 minutes the best 45 minutes? I don't get to see her for another week. You know, that's my type A-ness. She just one day came in and said, just enjoy your baby. Just enjoy him. Just enjoy him. Let's just watch him. Look at all the fun things that he's doing. And I don't think I'd ever, I mean, I came into the program wanting to be subjective. I wanted to be the mommy. I did not want to be the developmental clinician. And she gave me permission to do that. And I think in my head I was saying it, but I didn't feel it in my heart yet until somebody that I had trusted told me I could. So it just goes back to that whole, you know, we validate so that we can build trust, so that parents can hear you when you tell them to enjoy their baby.
Absolutely. And it's the premise that really should be at the foundation of how we develop our goals and outcomes, right? So we utilize natural environment practices, we utilize coaching practices for that very reason. And those practices are there to allow parents to enjoy their baby. And so when we're talking about things that they're doing, when we're asking questions about those types of things, and I know that depending on what the goals and all of that are, we have differing levels of parents, right? So we have parents who are very, very professional and they have the techno speech and the jargon and that stuff, and they are a little bit more rigid maybe, or more structured in how they do things at home. And then we have parents who are a little bit more laxed. And so it's thinking about what that family looks like. Like, to me, that's what makes this individualized, because definitely enjoy your baby, and what you enjoy doing with your baby is going to be very different, you know, from family to family, from home to home, you know. And then we come alongside our families and we support them in doing just that. So you can enjoy your baby and still support them in their gross motor development. You can enjoy your baby and still support them in their fine motor development. You can enjoy your baby and still feed them. You can enjoy your baby and still teach them how to put items in different places, and those functional skills that we work on in early intervention. So really, Tracy said it in chat, keeping the baby in mind and that relationship that is there.
Because at the heart of all of early intervention is the thing that connects it is that we just want to help families improve their quality of life with their children. That's it.
That's it.
Yeah,
and
that's it.
And not the way we would, right? Because that's the thing we have to remember, is that we're not trying to make carbon copies of ourselves when we go into homes. And so we don't have this family template that we're walking into and that we're using, and we got to make everybody fit into those little molds. But what does family look like to them? What is important to them? And that's what we go in and we support that family unit in. Yeah, absolutely. This is so great, Michaela. I am so, you already know how I feel about you just being here and taking the time to do this with us today. I am so grateful. Is there anything you want to say before we transition?
No, just thank you so much for having me and giving me a space to kind of talk about things.
Absolutely. Thank you so much, Michaela, for joining us. And I am going to share my screen again. Let's see if I could do this really nicely. We there? You guys seeing the screen?
You're good to go.
All right. Yay, I did it, Lisa. So I want to share a few highlights or takeaways from my conversation with Michaela, and just three things I want you guys to just take with you when you go away today from Michaela's sharing. And it's that connection is key. Remembering that your true gift is not your ability to be an excellent coach, but that you are an excellent coach because you have an innate capacity to connect, to empathize, to be intuitive, and to coach with compassion. So connection is key. The second thing is that we all need space and grace. And I saw, Lisa, that you put that in here in chat while we were talking. Give parents the space to share, to process, to be where they are, not where you want them to be. Everyone wears multiple hats and life can feel very overwhelming at times. Giving grace is key to establishing trust, understanding, and ultimately a relationship that is conducive to learning and growth for the whole family. And lastly, never underestimate the power of active listening and validation. Feeling truly heard is perhaps one of the most empowering votes of confidence that you can give to your families as they navigate through this journey. And these, you guys, I know that was written so beautifully, and I would love to be able to say that I wrote those, but I didn't. Those are Michaela's thoughts and summed up to share with you guys as her peers of the things that she takes away and that she wanted to take away, you guys to take away as well from her experience. And again, our connection is key. We all need space and grace, and never underestimate the power of active listening and validation. So throughout today's discussion, we've talked about ways to support families that may be described as special populations. Like today's objectives, I've taken the key strategies from part 1 and listed them above, as they're also applicable to these families. Observe and assess the parent-child relationship. Again, this is an ongoing process. Is what science-based information do we have? Ask yourself that. Do we have to help us understand the family's needs going into the home that will assist us in assessing the family's needs? Develop service plans that take into account the entire family. Each plan should reflect the family's unique needs and experiences. Think about the questions that we're asking. Remember, intake and assessment is not an interview, it's a conversation. Provide information and guidance and support to families to further develop parenting capabilities and the parent-infant-young-child relationship. Tailor information, guidance, and support to each family's individual needs. Support and reinforce parents' ability to seek appropriate care. Remember, avoid judgment, be kind and compassionate. Offer to connect families to resources. As early interventionists, we support child development by facilitating the building of caregiver capacity and confidence in their abilities and linking to additional supports as needed. We have the unique honor and privilege of being a pebble in a pond. Our actions as early interventions can have a lasting impact on each family we serve. As we consistently pause and reflect on our practice, we will begin to make not only shifts in our mindset about the postpartum period, but also see the needs of families through their eyes, meeting them where they are and helping them get to where they want to be. Thank you guys so much for your time today. Michaela actually has a longer interview where she goes into more information about her experience, and Lisa has popped that in chat. So thank you guys so much for joining us. Are there any questions? There's the reference list.
I'm going to go ahead and do
questions?
my thing. Well, you guys go ahead. Thank you, Telisha. That was so wonderful. And thank you so much, Michaela, for joining us today. If you guys have any questions, feel free to go ahead and put those in the chat box. I'm going to go over just some logistics really quick. So just hang on another minute with me if you want to go ahead to the next slide, Telisha. If you want to save the date for our next Talks on Tuesday on November 8th, just please take a moment to look at the date because that's November 8th. I know usually our Talks on Tuesdays are on the first Tuesday of the month, but because of the election day, it is moved to November 8th. So save the date. It'll be on digital distractions. And then you will receive an email. Actually, I accidentally sent the email a little bit early. I'm sorry about that. So there's an email in your inbox right now that has the link for the survey. So go ahead and click that and you'll get the certificate once you take that. And if you guys are on social media, feel free to make sure you follow us to stay up to date on the latest trainings and resources that we have available. And I don't see any questions. You see any so far? Lots of thank yous.
Kim Sprangle is asking, yes, Kim, it is a Monday. So pretend the new title is Meeting on Monday instead of Talks on Tuesday for just November, because our regular November date is Election Day, which is a state holiday in Virginia now. So just change your calendar for this one Talks on Tuesday.
Meeting on Monday. I like that, Corey.
That's pretty
great.
quick. Like, do I get any kudos for something like that?
That was good. Wonderful. Oh, so many things, and lots of thanks to you, Michaela, that's going on in the chat too. Thank you all so much.